as I mentioned a few weeks ago, when we did some of the Scholarly Year student presentations, we had 5 students this year. Our 5th student to present is Gianina Hernández Márquez, who comes to us from the University of Puerto Rico, the San Juan Bautista School of Medicine. I had the pleasure actually of meeting some of her faculty at the ASPN meeting, which they hosted this year. Really good group. She is a rising 4th-year student at that School of Medicine and came to us to do research under the mentorship of Dr. Germano for the past year. She's been very productive both at home and here, and is going to be presenting today on the topic of social determinants of health in the context of patients with glioblastoma. So welcome back, Gianina, and we'll also, I should mention, be welcoming her for a sub-I this summer, so keep an eye out.
Morning, all. Can you see my screen?
Yes, looks good.
Good morning. Thank you for the presentation. So today I'll be talking about the impact of race and social determinants of health on clinical outcome of GBM patients over a decade. Disclosures, I've done this work as part of the Scholarly Year here at the Department of Neurosurgery, and my mentor, Dr. Isabel Germano, has no conflict with the current presentation. So as most of us know, glioblastoma in adults is the most common malignant primary brain tumor. And for the treatment options, the ones that have shown significantly increase survival in patients have been maximal surgical safe resection, chemotherapy, radiation therapy, as well as tumor treating fields. In terms of the racial distribution in this disease, previously published data has shown that it predominates in non-Hispanic white patients, with around 80% or more of them self-identifying as white patients. Whereas racial disparities in treatment and in overall survival in different brain tumors in patients identified as non-white has shown a 25% decrease in 3-year survival compared to white patients. So even though GBM predominates in white, we've also seen that in terms of other tumors, non-white patients are getting affected by it in terms of survival. So for our study aim, we saw that in the literature, there has been some limited in the extension of racial diversity and how socioeconomic metrics have been used to analyze this study cohorts. And we've also seen that the social determinants of health have shown an impact in the outcome of diseases, even though we've had medical care improvement and disease prevention, they're still impacting the outcome. So we wanted to challenge the data in terms of these following questions. Is GBM a disease of the white population? And do non-white patients succumb to the disease faster? So the aim of our study was to analyze the influence of race and socioeconomic status on the outcome of GBM patients over a decade. For the methodology, we queried the institution's tumor registry looking for glioma patients, specifically the ones that had the ICD code for GBM. And in the inclusion criteria, we had adult patients 18 years or older. They had to have a histologically confirmed GBM WHO grade 4 diagnosis. And we had to be able to extract the clinical information, including comorbidities, as well as specific admission and discharge dates. We collected the following variables listed on the left side for the clinical part. And in terms of the comorbidities, we used the NCI comorbidity index, which looks at predicting the risk of death within 1 year of hospitalization in patients with these specific comorbid conditions that are listed on the table at the right side. And we wanted to see if these comorbidities were related in any way to the outcome of our patient cohort. For the socioeconomic data, we collected gender, race, ethnicity, health insurance, and zip codes. And we used those zip codes with the variables listed on the table at the right side to calculate the AHRQ SES index. AHRQ stands for Agency for Healthcare Research and Quality. And this is a socioeconomic status validated metric that has been used in previous studies. And with it, we were able to see if our patients came from either a low socioeconomic status or a high socioeconomic status. For access, outcomes, and quality data, we extracted the length of stay, discharge disposition, overall survival, readmission to the hospital within 30 days of discharge, admission to the emergency room, as well as a diagnosis of GBM in the emergency room. And we conducted univariate and multivariable tests for the analysis, and we looked at survival using the Kaplan-Meier curves. So for our results, we first wanted to see how our cohort compared to the previous data published. And we saw that we had 43% patients that identified as non-whites that received a GBM diagnosis, whereas the previous literature reported around a 20% of patients identifying as non-whites. We then proceeded to establish the benchmark comparing our study cohort with the New York State GBM population, as well as the US population. And our cohort, as you can see, mirrors more the United States population's racial and ethnic distribution. We have around 57% of non-Hispanic white patients, as well as 59% non-Hispanic white patients that are seen in the US population. We then moved on to look at the socioeconomic status distribution, and we found out that most of the patients that were categorized under the first quartile, them being patients that came from a low socioeconomic status, were identified as non-white patients, whereas patients of the fourth quartile, or the patients that were wealthier, self-identified as white patients significantly. And we wanted to see where our population was coming from, so we created this heat map. And here you can see in the legend at the top right, we have the AHRQ index distribution as well as the patient density. So we had patients coming from low socioeconomic status as well as a high socioeconomic status. Can you see my mouse?
Yes.
So, yeah, thank you. Mount Sinai is located around this area, and we can see that we had patients. Most of our patients came from the areas that have the green dot. So they came from high socioeconomic status, but we also had patients coming from poor areas. So we basically saw a fair distribution in terms of socioeconomic levels from the population. And in terms of comparing that AHRQ quartiles against demographic variables and against outcomes and quality measurements, we found significant results in terms of the length of stay. So patients in the lowest quartile had a longer length of stay compared to patients in the highest quartile. And even though they had a longer length of stay, we did not find a difference in terms of NCI comorbidity index. Moreover, we compared the racial and ethnic distribution against those same variables, and we did find a significant difference between patients that had private insurance. So 61% of them self-identified as non-Hispanic white, whereas 30% identified as non-white patients. So we had more white patients that were able to have private health insurance. And then looking at discharge disposition, we found significant results in terms of patients having private insurance. They were more likely to get discharged home, 2 times more likely. And patients younger than 65 years old were less likely to get discharged home. And additionally, we had those patients that got diagnosed in the emergency room, they had a lower probability of getting discharged home compared to those that got a diagnosis in an outpatient facility. We also looked at survival, and here we found that patients that self-identified as non-Hispanic whites had a higher, better overall survival, only if we looked only at race. And independent of race, looking at overall survival, we saw that patients that had private insurance at 2 years had a higher survival than patients that had public health insurance. So to sum up, our study shows that in a population sample where the socioeconomic status and the race are representative, non-white patients were diagnosed with GBM at a rate twice as reported in previous studies. Previous studies reported the white population making up 80%, whereas we found 43% of the cohort identifying as non-white receiving this diagnosis. And our percentage is representative and comparable to the US population GBM diagnosis patients, which reported a 40%. And then looking at the outcome and at the socioeconomic status, our cohort, as the heat map showed, was able to, our institution was able to treat patients with a AHRQ comparable to the one of the local population. So we saw patients coming from a poor background and patients coming from a wealthier background. However, we did see a difference in terms of the racial distribution regarding the quartiles. So patients at the lowest quartile were mostly non-whites, whereas patients at the highest quartile were mostly white patients. And these white patients were more likely to have private health insurance, which is linked to a higher rate of getting discharged home, as well as receiving radiation therapy or chemotherapy and better overall survival. And looking at the surgical intervention and at the healthcare access our patient cohort received, we did see that patients in the low quartile had a higher length of stay, but we did not find any difference or any disparities regarding the surgical intervention these patients received. So race, ethnicity, and socioeconomic status did not have any impact on the type of surgical intervention they received. Craniotomies were the most predominant surgical intervention, and they showed to have better overall survival compared to biopsy. We did see a 2.6% increase in terms of GBM first diagnosed in the emergency department compared to outpatient facilities. And we also saw that these patients diagnosed at the ED were less likely to get discharged home. We believe that these patients were probably getting to the emergency room with a more progressed disease, which could be due to them not having adequate access to primary care, which is one of the strategies we are proposing to address this. And also these patients that got diagnosed in the ED were more likely to be older than 65 years old. So we think, according to other studies, that this could be due to barriers, including transportation access, which is also another of the strategies that we would like to propose to study a little bit more to see if we can address this. We did not see any difference in terms of comorbidities among GBM patients within the different quartiles, as mentioned before. And within our healthcare system, we saw that barriers to healthcare access might not prevent patients from receiving an overall systemic care, but some factors may be delaying the patient presentation for neuro-oncological care specifically. And this could be influencing the disposition of their discharge. So to mitigate these barriers, we think that for those patients that have the longer length of stay and that are part of the lower SES quartile, but don't have NCI comorbidity increased, if we identify these patients upon admission and we try to increase the social worker efforts as well as the team that works with this, we think we can contribute to expedite their discharge and maybe try to gain a knowledge of what their support system is and try to decrease this length of stay. And also assigning a primary care physician to these GBM patients may improve care and decrease costs. And for the patients that are 65 years old that were more likely to get that GBM diagnosis at the ED, we think that if we identify steps and develop a type of program to sort out their transportation barriers, we can increase their access to care and maybe decrease those ED visits where they're getting the diagnosis. However, we do need more data, and we need to get a more in-depth grasp of what these barriers are from the patient side. For the limitations, race, ethnicity, and gender were self-determined. Gender was only reported as binary, and the data collection was not sufficiently granular to look at tumor size, extent of resection, and additional tumor molecular substrates and how they influence the outcomes of our cohort. And finally, this is a single institution study, so it would be ideal to replicate it at other institutions and to see what the presentation of GBM is elsewhere and compare it and maybe get more generalizable results. And to conclude, GBM patients with low socioeconomic status have worse outcomes independent of race. However, non-white patients in our cohort were predominantly affected by factors associated with a low socioeconomic status. We highlighted specific strategies to try to identify and mitigate these barriers. And we think that if we collect more data from other institutions, we can continue to enhance our understanding on how to improve GBM care and how to address these healthcare access barriers. Here are our references. I want to thank my mentor, Dr. Isabel Germano, for all of the mentorship she's giving me and the opportunity to work on various projects. I'm very fortunate. And also the team, including Cyril Babel, a medical student of your institution. He was very instrumental in this study. And I'm very thankful for the opportunity. If you have any questions?
Gianina, have you looked into whether it would be feasible to replicate this study with any nationwide sample databases, like nationwide inpatient sample, NSQIP, N2QOD? It seems like that might be a good way to collect a large amount of data across institutions rather than having to sort of create a multi-institutional collaboration on your own.
Yes, that's a very good suggestion. I have not, but I will take it into consideration. Thank you.
I just don't know if they have the specific field that you'd be looking for, but it might be worth finding out.
Okay.
Gianina, this was a fantastic presentation. You've done a lot this year. Congratulations. Gianina is very soft-spoken, but she has won multiple awards. She has been presenting at the AANS-CNS, and she will be presenting at the next year's meeting. She's also the recipient of the WebSum fellowship at our own institution. So she has really done a tremendous amount of work. I would like to thank Dr. Peter Morgenstern for putting her in touch with me. I will never forget the day that she emailed Peter, I think just with one finger, push one button and said, are you interested in talking to her? And that was a magic connection. So thank you very much, Peter, for establishing this connection. In reply to your question, Peter, some of the so Gianina made this look really simple and smooth, but the data collected is not as granular and straightforward as one would think. And so that is really a limitation of any of those databases. So we have the SARS database that we have access to, and we now have New York State, the entire state of New York that we are analyzing was finally granted to us. The problem really is that what Gianina and Zero did was many, many hours. I'm not exaggerating by saying that the Christmas holidays, the two of them spent 2 weeks manually sorting out into EPIC. So there is a big difference between what is stored in the cancer center data and what is really needed to do a study like they did. And this is why we need collaborators, and this is why you can't just rely on a database. So for what, the other thing that I need to mention is that this is done in collaboration with the Institute for Health Equity Research here at Mount Sinai. As you saw, Nina Bickel is one of our co-authors, and Lynn Richardson needs to be really thanked for giving us the opportunity to work with them. And some of the strategies that Gianina mentioned, they're not just wishful thinking, we are actually implementing them with our own physicians at Mount Sinai. So I think that for our own little group, we are making good progress in taking care of all patients coming in with GBM.
Greg, you had a question?
Hi, yeah, this is Greg Capinos at Elmhurst. I wonder if your data has, if your data set has the ability to see how many patients were actually diagnosed and had access to a neurosurgeon. However, basically the surgery was not performed. One aspect of the ethical issues that I've analyzed in terms of trying to enhance equity is the fact that because of the consent process, which on face value is a good thing because we want to align our surgical or the goals of care with the values and the preferences of the patient, that has been actually coming at a detriment to the patient population who are unbefriended. And we know that social economic status is also related to, do you have a cell phone and do you have a healthcare agent or actually even a next of kin that is reachable? And many times I've seen patients, unfortunately, where the consent process has been actually a bad thing, preventing patients not access to care, but actually implementation of care. Like, did we go to the OR to resect that patient, or to put an EVD for hydrocephalus for other things?
Greg, thank you. I think you made your point. I think that data was reported, right? They said that they all got same number. There was no decrease in surgery.
Correct.
Gianina, I really thought you were going to say the most important part of your question, of your results, was that you've essentially shown that the data is wrong on the incidence of GBM.
Well, that's what we saw in our cohort, yes, but I don't believe we can generalize this yet. I think we have to look at more.
To me, that's one of the most interesting observations you made. And if it pans out across New York State, you will have changed. All the textbooks then need to be rewritten.
Yes, that's true.
And just to be clear, when Gianina was showing the graphs about the population, that population is not the population with GBM. That is New York State population and the US population, nothing to do with the disease. So our cohort, if any, we are not serving enough non-whites, right? So if you look at that slide number 2 that Gianina showed, we still have ways to go. So even here in Mount Sinai, where we're performing surgeries across the board without differences in socioeconomic status, and our population is 43% non-white. We still have room to include more non-white because our sample is still less, has still less non-white patients than the New York State population.
The other question I had pertains to your conclusion that low socioeconomic status patients do not do as well. What you've shown is that from the time of diagnosis, they don't do as well. But you've also suggested that they're presenting later in their course.
Yes.
In fact, right, you suggest that one of the reasons they may not be doing as well is because they present later in their course, right? So what you don't know is when did the disease begin?
Yes, that's why we were proposing trying to address that primary care side to see if they have, if we can increase their access and stop them from getting to the ED or to presenting so progress.
Yeah,
That's why.
I get it. I totally get that, but I'm trying to make a different point. If you were to take, you know, I can imagine this visually, but you've got the time of diagnosis and the time of death.
Mm-hmm.
And what you've shown is that in the two groups, death comes earlier relative to the time of diagnosis in those presenting to the ED or socioeconomic. But maybe that shift does not mean they're doing worse because you don't know when the disease began. In fact, you've suggested that they're being diagnosed later.
However, in the multivariate analysis, there was no difference in socioeconomic status and presentation to the ED. So the two are not linked. So it might have transpired throughout the presentation that is the case, but that's not the case. So there is no link between socioeconomic and having more ED diagnosis. What Gianina showed, which is across the board for all specialties, not just neurosurgery, is that over the decade, there has been a trend in more people presenting to the ED, 2.6, and in some of the other surgical specialties goes up to 15% more ED visits for first diagnosis. But multi-analysis statistical determination did not link being poor and coming to the ED more frequently.
I think it's incredibly sophisticated data analysis, beautiful work. And I'll just point out that like Zero, Gianina is able to sit here with a bunch of old neurosurgery people and attendings and handle herself very, very nicely, which if you remember back to the days when you were a medical student is not a very common thing. So congratulations, Gianina.
Thank you so much.